of the oral cavity. Now, when we talk about the anatomy of the oral cavity, it becomes easy for us to understand that the upper and the lower jaws are technically made by a series of bones. So, if you understand this picture, which becomes easy, because what I am trying to show you is technically a floor of the mouth which is made up by a mucous membrane and muscles like the mylohyoid. But if that is the floor that is technically made, remember that we are now concerned by the teeth and definitely by the tongue, which will be an important part. Now, whenever we are talking about the floor of the mouth, and what becomes important is that the parallel point where the hard palate and the soft palate meets is technically called as a circumvallate papilla. Now, the circumvallate papilla will thus make the anterior 2/3 and the posterior 1/3 of the tongue. So, beyond this level of the soft palate, we will be getting nasopharyngeal cancers, particularly of an important opening of the eustachian tubes. And remember that nasopharyngeal cancers will have a propensity to block the eustachian tubes and may be a cause of an otalgia. Whereas if you talk about in the lower parts about the inlet of the larynx, and the minute we talk about the cricoid cartilage and the inlet of the larynx, we have areas like the fossa of Rosenmuller and the pyriform fossas, which will come to become important in delineating the difference between an oropharynx as well as an hypopharynx, which is made by a distinction between by the sides of the pyriform fossa. But we will not be talking beyond that. We will be again coming back to our descriptions on oral cavity. Now, let me take a marker pen and show you what exactly how much is the oral cavity. So, posteriorly, we have a line that delineates between the hard palate and the soft palate. So, that means if you have seen that the soft palate is thus technically not a part of the oral cavity. Whereas anteriorly, as you can see this, definitely we are interested in the hard palate to be, because the maxillas and involvement of the maxilla is going to be an important part of what you are required to know now. When you talk about how much is it down, again as I have said, the circumvallate papilla of the tongue is something that makes the line very clear. So, your oral cavity will technically end at the circumvallate papilla, whereas some people say that you can also add the anterior pillar of the tonsils in this. Remember that they are technically not in the, so the tonsil is technically not said to be in the oral cavity. So, in the oral cavity, it would end at the circumvallate papilla. You can extend it laterally till the anterior pillar of the tonsils. The tonsil is not a part of the oral cavity. Now, anteriorly, as you can understand very easily, we have the mandible and we have the maxilla with the teeth, maxilla teeth and the mandibular teeth, whereas this is the floor of the mouth, which is initially seen with the mucous membrane, which is translucent, as well as two muscles, the geniohyoid and the genioglossus, which becomes very important in the genioglossus and the geniohyoid, because when you have cancers in the floor of the mouth, or when you have cancers infiltrating the mandible in this region, it becomes important to understand that excision of such cancers, particularly taking the loss of the support of the tongue, will be important in the post-operative perspective when you need to plan for a airway management. So, if this is the boundaries again, so as you have seen, so again to recapitulate, I will use the marker pen to make you understand. So, the oral cavities technically will extend into this squarish region, and all the cancers that we are going to discuss will be thus technically divided into 8 subsites. So, in the subsequent lectures and in the lectures on the clinical examinations, as you will see, you will get 8 subsites of oral cancers, and depending upon the subsites, the surgical management and the techniques do differ. So, that is what is important to know about the oral cancer. 8 subsites also becomes very important when, as a part of a public health program, you are planning a screening of an oral cancer. Now, Coming on to what exactly is the etiology of oral cancer. When you talk about oral cancer, as you can see on your screens now, it becomes important to understand that the main point about oral cancers are majority as modifiable factors. So when you talk about non-modifiable factors like age causes an incidence to be increased, but there are other modifiable factors which becomes very important to tell patients and to tell relatives of the patients to avoid smoking, alcohol, betel nut. Sexual practices like orogenital sex may be associated with human papilloma viruses. But what is more important for us to understand is the role about these agents, the smoking, alcohol and the betel nut quid, each of them to have a synergism. So each of them will produce their own effects of these. Now when you talk about points that will include, say for example, smoking. Tobacco intake in any form, it can be smoked tobacco, it can be chewable tobacco, particularly smoked tobacco will have the effects of burns, etc. on this. But on an overall, if you understand, the mechanism of action will be generation of polycyclic aromatic hydrocarbons. So smoking and tobacco increase is going to produce polycyclic aromatic hydrocarbons, which will produce a problem with DNA repair mechanisms. So this is something that you are asked very frequently in an examinations. Okay. Now, whenever we talk about alcohol, does alcohol produce an independent? Yes, it does, because alcohol is known to produce a metabolite called acetaldehyde. Now, the acetaldehyde induces CYP2E1, and that promotes a change in the mitochondrial DNA and thus again producing a last transcriptional changes in proteins that are responsible for maintaining the integrity of the cells. Now, what is more important is the synergism that we need to understand between the tobacco and the alcohol. And remember that alcohol will produce more dissolution of the tar agents to produce a field change. So alcohol and tobacco are thus usually considered to be, as I've said, synergistic. Now, when you talk about smoking, remember that e-cigarettes, vaping, has always been considered also to be an etiology. So if you are thinking that vaping does not produce, the story is exactly not the same. By 2016, there has been warnings that vaping may also be associated with an increased risk about oral malignancies and pre-malignant disorders. Now, talking about pan and the betel nut quid. Now, definitely with the increased intake of betel leaf, which is the pan patta, what is more important is that the betel leaf will produce something called alkaloid, which are important for dissoluting the chemicals. Now, the pan, if you have understood, will contain other materials like, say for example, it will contain some amount of supari, which is usually a betel nut. Okay. Now, in an Indian perspective, it is called as a supari, and this betel nut will produce something called arecholine. This arecholine etc. produces vasospasm, and is also induces the activity of matrix metalloproteinases 2, which are responsible for induction of fibrosis or oral submucosal fibrosis. Now, what is also important is that it can contain slaked lime, which is calcium hydroxide, which is itself a very strong alkaline irritant to the mucosa. So as you can see, pan will have multiple ingredients in the pan. The pan patta liquid is called an alkaloid, which helps in dissoluting the materials. What is important is a word called quid, which is a product when someone chews the pan along maybe with a material called pan masala, which may be a form of a tobacco which is powdered, though there are many pan masalas which claim they do not have a tobacco, but again they will have other grounded forms of betel nut, etc. So the basic essence in the story is that these agents are avoidable and there are higher incidences if someone has a chance of consuming these agents.